I'm Dr Phil Mitchelmore. I am a respiratory consultant at the Royal Devon and Exeter Hospital and an honorary senior clinical lecturer at the University of Exeter Medical School. A particular interest in me is around chronic lung infection, particularly in people with cystic fibrosis and bronchiectasis, and I'm the clinical lead for the Citizen Phage project. Thinking about my role as the clinical lead in this project, there's three main strands really. So in the first instance, we're providing clinical insight and identifying clinical need for phage therapy. And then in my day-to-day job, I come in contact with a lot of people with chronic lung infections. So this gives the opportunity to invite them to donate sputum samples, which will contain these bacteria that we want to treat. And this will enable us to do some of the laboratory work, looking at the phages competing against the bacteria. And then the third strand, and what we're ultimately aiming towards, is the development and the delivery of clinical trials, so we can see if phages can be a safe and effective long-term therapy in chronic infection. I think phage therapy as an entire field's fascinating, and I think this project can be a really crucial step in the overall side of things. If you're looking at why it's important, the projections of the impact of antimicrobial resistance in the next 30 years are absolutely frightening. And there's going to be lots of ways that as a global population we look to address this. So this will involve, hopefully, the creation of new and better antibiotics, also us using the antibiotics we already have more responsibly, but also think about alternative and novel approaches to treating infection. That's where phages can come in. And I think one area that is so enticing about phages is not just can they be an attacker and killer of bacteria all by themselves, but there's this potential for them to enable antibiotics which have become resistant to be useful again. And essentially with the competition between the bacteria and the phage may allow for antibiotics to work again. So for those reasons it's hugely sort of enticing concept and potential therapy. From a sort of closer to home and more of a sort of personal experience and perspective, we're seeing lots of people with chronic lung infections who are needing to take a huge amount of antibiotics just to try and maintain some control of their condition. So this can involve sort of having to inhale antibiotics twice a day, every day, or be taking antibiotic capsules or tablets every single day, even when they're stable. On top of that, they may need 2-week courses or longer courses of antibiotics into the vein just to keep them well. So to be able to provide a therapy which can make a difference in this battle against the bacteria and potentially improve quality of life and reduce the antibiotic burden for these people that we're seeing regularly would be fantastic. And if we sort of think about the antibiotics that we're using in regular care in cystic fibrosis and bronchiectasis, there's many knock-on effects of these treatments. So the inhaled antibiotics can sometimes make people really quite wheezy, and these are people who are already struggling with breath. So then to make them more short of breath is clearly counterproductive. On top of that, they can have impacts on the other bacteria in the body, and this can have an impact not just on their lungs, but outside their lungs, particularly in the gut. And a lot of the antibiotics that we use for long-term control for these people can quite often give tummy upset and the like. So opportunities for therapies which can reduce the impact of antibiotics, both from the resistance side of things, but also from the side effects of these patients, I think is really, really important.
What was your pathway into this field? How did you get to this role?
So I started my specialty training in respiratory medicine about 10 years ago. And at the start, I had two excellent mentors who have a clinical interest in bronchiectasis and cystic fibrosis. And this sort of really nurtured and developed my interest in this area. With their help, and also with scientists at the University of Exeter and at the medical school, I was able to undertake a PhD looking at chronic lung infection in people with cystic fibrosis and bronchiectasis. And so this furthered my interest and awareness of the need to try and tackle this area. And my interest has continued to grow ever since. Through the people I've met at the university, I was put in touch with Ben Temperton, who's leading on this phage project. And with ongoing discussions with Ben and a greater awareness of phage therapy, it's sort of heightened my interest even further and my wish to be involved in it.
I wonder if you can tell us a little bit about your role on a day-to-day basis. You do research and you treat patients directly? How does that work?
So My primary job at the minute is as a consultant at the Royal Devon and Exeter Hospital. This will involve inpatient care of acutely unwell people with respiratory illnesses, and at present also with COVID. Outside of the inpatient care, we also perform outpatient services where we run specialist clinics for cystic fibrosis and also for bronchiectasis. So through that we're looking after a lot of people who do have these chronic lung infections. Around that I have an appointment with the university as an honorary senior clinical lecturer, and that allows me to continue on with the research I started during my PhD and to be able to work with the fantastic scientists over at the university. If you think about the potential impact of the Citizen Phage Library, from the first point of view, just being able to have a really well characterised and catalogued library in the UK for phages is just a fantastic starting point, because we can't go any further unless we have access to these. And the project and the way it's been set up is fantastic of engaging the public to be involved in this and to become phage hunters, so that we can build up this comprehensive bank to use in the future, hopefully, to make people better. Being able to treat people who have long-term chronic infections, who for decades struggle with their illness and the burden of that, would be such a fantastic outcome. If we move beyond that, it's an opportunity to highlight phages as a potential treatment in lots of different areas with regards to infectious diseases. And the more areas where phages can be shown to be effective, the more likelihood it'll become effective in a variety of other fields, and hence reduce the global problem with antibiotic use. And then, as we keep coming back to, with antimicrobial resistance being sort of this global crisis, anything that can make the antibiotics we already have more effective is going to be absolutely crucial moving forward.
Do you have any or many patients who have drug-resistant bacteria that aren't responding to antibiotics at the moment here at Exeter?
Yeah, so sort of our cystic fibrosis unit and our bronchiectasis service combined will have over 400 patients. A large number of those patients will have long-term infection. A particularly prominent one in this patient group would be Pseudomonas aeruginosa, which is identified on a global scale as one of the key pathogens with regards to antimicrobial resistance. These patients will be receiving a huge amount of antibiotics, and many of the bacteria in their chest will, as a result, be developing their antibiotic resistance mechanisms to them. So just in this one hospital here, we'll have a large number of patients with infections that we aren't able to eradicate at the minute, and are at the moment just trying to hold with ongoing antibiotic therapy. So if you then think beyond Exeter, there's going to be enormous numbers of patients in the country who have these chronic lung infections which cannot be at present cleared by the antibiotics we're using.
How difficult is it to carry out the clinical trials for research like this?
Yeah, so it's really difficult to do clinical trials well, and it's so important to do them well. Where we're at with phage therapy at the minute, the initial trials will need to be small and looking at sort of showing biological plausibility that they can work for chronic lung infection. So in the first instance, this may just be showing that we can deliver phages safely to the lungs and that they can reduce the number of bacteria essentially in the lungs. Once you're able to show that, then you can start building towards bigger trials and looking at really important outcomes for patients, such as long-term survival and how they feel in their day-to-day life. So it's small steps building towards those important trials down the line. It's a tricky one with all the steps that we'll need to go through to get there. But I would hope that we'd be able to be doing those first initial trials within the next 5 years. You may be looking at 10 years before you're able to do large multi-centre studies, which will help towards hopefully delivering phage therapy as a viable long-term therapy in standard clinical practice. Yeah, I certainly think it is a fact that a lot of clinicians are not aware or only have a very distant understanding of phages. And I certainly remember being in clinic a few years ago and a patient came to us discussing phages. And it was an area that at the time we had very little knowledge of. And I think it is going to be important, hopefully when clinical trials show benefit with these, for physicians and clinicians to be aware of this. And I think any promotion is obviously going to be helpful, but ultimately the thing that will sway clinicians towards using these will be successful clinical trials, and that's why this initial research and building towards clinical trials is so important.